We don't do an early sphincter, at least I don't do an early sphincteric release. There you go. And then once you are away from the area of the sphincter, you can start enucleating the upper part of the lobe by pushing it down, as you will see in the next video. So following that, you're safe and you can push the rest of the adenoma down. Right, so once this is achieved, then you stay to 12 o'clock position, and like I said, you push the left lobe down, in a downward movement. As you can see, it feels nicely here. And the next thing you will need to do is to merge those two planes, the plane that you have already created at 12 o'clock with the plane that you've created on the lateral side of the left lobe. This is not always easy, but by experience, you will finally be able to merge those two planes, as you will see later on. As Dr. Mizrahi said, you literally dance around the adenoma, finding any areas that the adenoma is attached to the capsule. As you can see here. And once you feel that it is completely or almost completely free, then you push the adenoma towards the bladder. I'm going to the end of the video. There, the adenoma is pushed inside the bladder, the left lobe, and as you will see, it's only attached by this bridge of tissue. And the left lobe is now inside the bladder. The procedure is repeated on the right lobe. And finally, you end up with the prostatic cavity that looks like this. There's usually a small amount of bleeding. However, you will need to be very meticulous in hemostasis because it is difficult to have good vision through your nephroscope while you're doing the morcellation if there is significant bleeding. That's the final touch. And the morcellation is the last part of the procedure. Like Dr. Mizrahi said, it's not the part when you get to relax because disasters can happen during morcellation. So that those are the rules for safe morcellation. Have meticulous hemostasis, keep the bladder full at all times with the second giving set through the nephroscope. You need to stay in the middle of the bladder with your blades facing upwards, and always be sure that you have prostatic tissue engaged between the blades when the blades are moving. Never morcellate a piece that is attached. And last but not least, I would say the most important is to train your OR staff and let them know that this is a very crucial part of the operation. Right, so what next? You put a three-way Foley, 20 or 22 French with 20 mL in the balloon. And just keep the irrigation for 3 to 4 hours and then talk the patient next day with excellent results. As you can see, this upside down. This is a patient with a 50 mL per second Qmax a month following enucleation by polyp. So how to avoid or deal with complications? This is a very nice discussion. I'm going to just briefly touch on some issues. I rarely had a case of capsular perforation with bipolyp. A couple of times I had to use the rollerball for cases of bleeding from the venous sinuses. I normally give Lasix at the end of the case. With bipolyp, as was mentioned before, it's too difficult to damage the UOs compared to the laser. However, if you are not able to see the UOs after, or you have some second thoughts about the UOs, then you should just do ultrasound at the end of the case. I've never had problems with BIS balls. Those are very small and actually very thick pieces of tissue which you cannot remove through the morcellator. Just need to use graspers and remove them. Urethral strictures, the same incidence as with bipolar surgery. And this is the long discussion on how to deal with patients on DOACs, newer anticoagulants. I just ask the patient to stop 3 days before and start within the next 2 weeks if the urine is clear for more than 48 hours. Just couple of advice for colleagues who would like to start doing enucleation, bipolar enucleation. Don't hesitate to convert to TURP because it takes like seconds to convert to TURP. If you're doing bipolar, you just change the loop. If you feel that the anatomy is unfavorable or your level of expertise is not that great, it's okay to do subtotal enucleations or even one lobe enucleation in the start of your learning curve and have a low threshold for bringing back the patient for clot evacuation or bleeding in your initial learning curve. This is a problem I had with in the couple, actually that was the last case of nephroscope malfunction. So the adenoma was pushed inside the bladder. The nephroscope did not work. Actually, it was, you couldn't see through the nephroscope, so I had to resect the tissue inside the bladder. You can do that, or you can just put a catheter and ask for a new nephroscope. This is not the case in Greece. You will need to order a new nephroscope. This will take months. So I just sat and tried to resect the enucleated prostatic tissue. This is not always easy. Sometimes it is tricky because the tissue doesn't stay, and you will have to actually push the tissue towards the beak of your instrument to take good bites. I had, in terms of complications, I had 2 cases of bladder injury during my learning curve. That was due to OR staff, like mentioned before. They forgot to replace the irrigation. So I would like to end with a couple of pros and cons for bipolar. It is, for me, it's a very familiar technique to the average urologist who would like to start doing enucleation and has significant experience with TURP because you can easily convert to TURP in seconds. And in terms of cost effectiveness, is more affordable than HOLEP. However, as you probably watched in the videos, it's less precise technique of cutting tissue. And if you got bladder stones, you will certainly need some kind of laser, preferably HOLEP, in order to deal with the stones as well. And I will leave you with a famous quote from experts in enucleation. I do believe that we're moving towards the era of anatomic enucleation of the prostate, irrespective of whether this is done with electrosurgery or laser. I think that we should forget the term gold standard for TURP. As Dr. Gomez-Sanchez said, it discourages change and improvement. And a very nice editorial authored by Dr. Misrai, saying that we have to distinguish familiarity, which is what we're used to be, what we're familiar with doing, to what is the best thing that we can do and offer to the patients. So move away from what we're familiar with to something that is actually more efficacious in terms of symptoms relief. Thank you very much. I like this cartoon. It's from a friend of mine, Yannis Kartalas Goumas. It shows how you can do enucleation in like 5 seconds, something like that.
Thank you very much, Petros, for this excellent presentation. In fact, I have to say thank you very much also for your friendship. You have a lot of merit because you are working in a public hospital where time is very important. And when you have to start a new activity, I think it's always difficult to take your time to convince the anesthesiologists and the long lists of patients that you are doing something that is best for the patients, and you have to continue. So all these problems you are describing, the second nephroscope or things that should be a non-problem, sometimes it's very difficult, and for your time and for your heart, it's difficult to
Thank you. Yes, Andreas, you're absolutely right. This is a problem that we have in public hospitals. For instance, my nephroscope is broken, and there's a problem with storage equipment. It will take like 3 to 4 months to have it replaced. So just tip of advice, if you're going to do bipolar, buy 2 nephroscopes to start with, because it will eventually break or malfunction at some point. Yes, it is difficult to do bipolar in a public hospital, the waiting list, the pressure from the anesthesiologist. My first cases with my mentor, Professor Luswaidi, it took us like 3 hours and a half So yes, you will need to be patient. And like Dr. Gomez Santos said, you will need to be committed. Otherwise, you will not do anything.
Can I have the microphone to Dr. Meneghini, please, who is our international expert in bipolar?
Thank you very much indeed. Many compliments for your presentation. I would like to make some remarks about bipolar. Starting late 2013, in a very small hospital in Italy, like Christopher Columbus, left the port of Cadiz, fleeing west with no maps, with no GPS systems, trying to do something that could resemble what I saw done by Fernando at the top gun of the whole surgery, try to replicate it with a simple semilunar resection loop. Okay, and thereafter we met with Thomas Herman, and we acknowledged that we are doing exactly the same thing. He was working in a very huge hospital. It was a lot more of possibilities and option to be done, and I continue to working in that small hospital. But what I strongly support is that today bipolar is fully included in the family of AEP. I mean, there is no difference in technique, and there is not a variant of TURP. Because this is the most important mistake that you could do, because you got to forget, because TURP is a plain snooker, to and fro. Enucleation, whatever technique you're using, is a swinging technique, like playing golf. And this is the first difference, complete difference from TURP. The second one is that I am a sort of bastard enucleator, because I started with bipolar, but 3 years ago I had audio laser too. And so I transferred my experience with bipolar in my laser surgery and to some of the laser surgery into bipolar. And I mean that the first thing to do, as Fernando has clearly stated many times, is to put insecurity in the sphincter. So the first time to do is put the sphincter in the safe. So disconnect the mucosa to avoid tearing. It's so reduced the incidence of early urinary incontinence. And after you can do anything, because as Petros rightly stated, is that bipolar is much more blunt technique, because the Herman loop is a very nice instrument for blunt section. If you're doing things blunt, the risk of tearing the sphincter are much more probable than using a laser. So my opinion is that first thing to do is to put the sphincter in safety, and thereafter you can do anything you want. And there, in recent times, I applied the suggestion of Thomas Herman of leaving the dorsal flap, mucosa flex. So I did it inside at 12 o'clock, and inside at 11 and 1 o'clock, and I leave this slide of mucosa. And this is another very important jump to maintain sphincter integrity. Herman loop is very nice. It's a very nice instrument. Has an excellent hemostatic properties. And the last thing I want to say is that a very important thing for any of these techniques, you should be humble. If I'm not able to do that, I cannot pretend to do anything at the first time. I gotta study a lot, so a lot of movies, but the most important thing is to have a proctor. I gotta have someone who's with me. I go to his hospital and he comes to my hospital to let me do the things for the safety of the patient first in the proper way. And this make me the possibility of a less steep learning curve. Otherwise, it can be very frustrating. And a lot of people in the past start with HOLEP. They bought a 100 watts audio laser that was put in the basement and forgot, because they have so elevated, so huge urinary incontinence after that they abandoned the technique. The technique is absolutely outstanding with any tulip, holmium, green, whatever else. It's nice. It's nice, and I think it is actually much better, even in the long period, because I have some operation made in the 5-7 years ago, where a huge prostatic fossa today, and the patient is very happy about that. But I think that tomorrow, if Stavros and you will allow me, I don't know which is the medium proficiency in this technique of the audience, but these people are coming today, probably they are not so expert like Professor Roche or Fernando in the business. And so I will try to perform, as Petrus has shown, a sort of 3 lobe techniques, because it's much easier to learn the in block that I do perform, even with laser and with bipolar, is a part of arrival. It's not a part of starting. It's difficult to teach in block technique from the beginning. Probably it's better to start with something easier, and thereafter you move to something more complex. I don't know if the other panelists agree with me, but if you allow me tomorrow, I will try to do that. Okay.
In fact, we are eager to see your technique and tomorrow morning, and of course we will have the possibility to discuss the different techniques and possibilities. And this is a master class where there are mostly trainees, so people, colleagues that need to learn, need to choose what technique they are starting with, if they buy a holmium, a thulium, or if they start with their basic bipolar source of energy. So it will be very important to see you.
We will perform an exercise of surgical democracy, since democracy was born in Greece 2,500 years ago. So we put people in the agora and we'll decide what to do, okay?
And at the end of the meeting, we will vote. And everybody here and the online colleagues that are seeing us, they are more than 100 inscriptions. So we'll try to see what they are choosing and who convinced them.
I'm gonna vote for my friends, not for the best.
I don't know if Professor Giannakopoulos is nearby. I've seen him. You have the chance to see him among us. In fact, I had a question for him. Do you have any more questions concerning all these techniques? We would thank Professor Soudoulides for his presentation. Well, I remind you that we have a simulator program now for everybody that is interested. For the others, we will prepare. Everybody is invited for the dinner. Okay, at 9 o'clock, there is the bus departing from the hospital for the center of Thessaloniki. So I thank you very much for today, and we will see each other tomorrow morning for the live surgery. Thank you very much.